Welcome to Grand Rounds in Population and Public Health Sciences. My name's Howard Hu. I'm the chair of the Department of Population and Public Health Sciences here at the Keck School of Medicine. We are welcoming our very special guest from Yale, who founded the Yale program in healthcare and environmental sustainability, Dr. Jodi Sherman. But first, we're going to hear some welcoming remarks from our dean. Please welcome Carolyn Meltzer.
So I will keep my remarks very short because we all want to hear from Dr. Sherman, and I want to applaud Dr. Hu for bringing together a multidisciplinary team here today to talk about such an important topic. I am proud to be at this institution that takes climate change sustainability to heart in everything we do. And healthcare is, as you know, a big polluter. My own field of radiology contributes a lot to that. So we've had a lot of discussions in my own field. I'm interested to learn more. There's so much we need to do, and it is, sustainability is, as everybody here knows, integral to the health of our communities in every way. And no better platform than the Department of Population and Population Health and Public Sciences to bring that, public health, okay. I know, I'm sorry. So to bring that forward in the work that's being done, looking at our communities, looking at the intersectionality of many factors. And I'd also like to say, you know, since I came to Southern California, everybody said it never rained, it was sunny and warm. And so I hope that I didn't contribute to climate change by coming here. But, I will turn things back to you to introduce our wonderful guest lecturer.
Thank you, Dean Muslim. When Carol Folt, our president, arrived as the new president in 2019, she declared that sustainability was going to be her signature initiative. Both Rob McConnell and I, and Rob I'll be introducing in a minute, had the privilege of being recruited to President Folt's university-wide committee on sustainability in terms of the research, the operations, and the educational subcommittees, and we joined the research committee. Rob and I were happy to discuss the many environmental health ideas that came to mind because that's one of the big strengths of our department, major research programs on air and chemical pollution. But somewhere along the way, we were reminded of a key insight advanced by Jodi Sherman in her 2019 editorial in the Journal of the American Medical Association that healthcare itself was responsible for 8 to 10% of carbon emissions in North America. So we asked the operations subcommittee, which is chaired by Dr. Sharma, actually one of our professors here, which has been pushing towards a fantastic suite of sustainability initiatives to make USC go green. What's happening on the medical campus? Well, we kind of got the equivalent of some shrugs and dunnos, and that's when we got to work. And in 2021, with some of our colleagues across campus you'll hear from today, the Keck USC Initiative on Sustainability in Healthcare began. We're really grateful to Practice Green Health, an NGO that has been leading in the national movement to try to green US healthcare, which has become both an operations and research partner to our initiative. We're grateful to Steve Shapiro, the USC Senior Vice President for Health Affairs, who instantly grasped the importance of the initiative and mobilized Keck leadership to advance sustainability, and to Dean Meltzer, who shortly after arriving in 2022 endorsed the initiative and has supported us in some critical ways. A key early support Dean Meltzer gave us was to bless our very first grand rounds in this issue by co-branding it as one of her first Dean's Transformative Lecture Series. Dr. Victor Zhao, the president of the National Academy of Medicine, was here in November to discuss NAM's Action Collaborative on Decarbonizing Healthcare. In this context, we welcome Dr. Jodi Sherman, who has continued to provide intellectual leadership on this issue, particularly as it relates to clinicians. The moderator of this session is Rob McConnell, a superb physician epidemiologist who also is the chief of our Division of Environmental Health and also the PI and director of our NIH-funded Southern California Environmental Health Sciences Center. Please welcome Dr. McConnell, who will introduce the panelists, and Dr. Sherman.
thank you, Howard. If I could have the panelists come up and take a seat, I'll start introducing Dr. Bhavna Sharma. Dr. Sharman's a civil and environmental engineer and assistant professor in the School of Architecture. Her research focuses on how to reduce embedded carbon in that is the emissions resulting from construction of new buildings or remodeling buildings. She has an interest in improving manufacturing methods, including the use of engineered bamboo in a variety of applications to construction. Dr. Mishkadian, Naj Mishkadian is a professor of civil engineering and also industrial and systems engineering. His research is concerned primarily with the risk reduction and reliability enhancement of complex systems like healthcare or hospitals, and in particular at the juncture between quality and sustainability. Dr. Mishkadian is he's a member of the Joint Commission and has a lot of insight with regard to that. Our third panelist is Arash Motamed. Arash is an associate clinical professor of anesthesia. He's the vice chair of clinical operations for anesthesia and the medical director of the main operating rooms, the medical director of sustainability, and the chair of the Integrated Patient Safety Committee at Keck. He's led multiple initiatives here on reducing the perioperative carbon footprint, including discontinuing desflurane nitrous oxide and reducing propofol waste. So, and now I'll introduce the headliner, Dr. Jodi Sherman. Dr. Sherman is an internationally recognized researcher in the emerging field of sustainability in clinical care. She's interested in life cycle assessment of emissions related to healthcare and the relationship to health outcomes, and in particular on how that relates to clinical decision-making interventions that are possible by clinicians and management. Her work is quite multidisciplinary. She's a member of the Lancet Countdown on Health and Climate Change, was a contributing analyst to the UK National Health Service Net Zero Initiative, and she serves on the National Academy of Medicine Action Collaborative for decarbonization of the US health sector. She also leads the co-leads the Lancet Planetary Health Commission on Sustainable Healthcare. So welcome, Dr. Sherman. Thanks for...
Well, thank you for this great honor of presenting to you today. Thank you, Dr. Hu and Dr. McConnell, for your invitation. So a little bit about me. I am a practicing anesthesiologist, and my interest began during my training, during my residency. I get asked that question a lot, when did it start? And that it began there because it was so fun taking care of patients, so rewarding, but also very obvious we have a problem. We're using all this stuff, we're throwing away a lot of this stuff unused, we're wasting a lot of stuff, even the stuff that we're using. It's coming from somewhere, it's going somewhere, it must be causing some harm to the environment and public health, but there was no information to guide practice improvement. And so that began my journey of trying to improve the practice of healthcare at the same time as wanting to be a clinician. So a lot of this is coming through the lens of myself as a clinician. By disclosures, I do have some grant funding from the Canadian Institutes of Health Research, Commonwealth Fund, and I do serve as faculty for the Institute for Healthcare Improvement. And so today, a really high-level journey. Hopefully, by the end of this talk, you'll be able to identify a relationship between healthcare pollution and disease burden. I know this audience is quite familiar, so I'll try and keep that part to a minimum. To be able to define what life cycle assessment is, or LCA, summarize some of the latest healthcare pollution findings, and ultimately describe opportunities for investigation and also practice improvement. And so why sustainability in healthcare? Well, pollution is a leading cause of morbidity and mortality, responsible for about 16% of premature deaths globally. And as you heard Dr. Hu say, healthcare itself is a leading emitter of environmental pollutants, which is against our mission to first do no harm. And as we were talking about earlier, reducing healthcare pollution can improve the triple bottom line, or we'll call it a quadruple bottom line by the end. That's the best care for the most patients at the least cost. And part of what motivates me in this work and to get out of bed in the morning is that healthcare is such an enormous part of our economy, and everybody in their life at some point is touched by healthcare. If we can transform this industry, I really believe it's a key to transformation. And so this talk will be a lot about climate change, but it's not the only threat facing planetary health. These are this is a famous work by Stefan and Whitney, and the boundaries of planetary health. The red meaning we're outside the planet's ability to regenerate itself, so of course climate change is a big part of that. Also, you've heard of biodiversity loss. We're in the midst of the 6th great mass extinction, which of course is related to land misuse and so forth. So obviously we can reduce healthcare pollution by providing less care. That's not the solution, because at the same time, we have to lift up our population and make sure that everybody has their basic needs met. And so somewhere in between there is called the donut, if you're familiar with donut economics, where we live beneath the ecological ceiling and above the social foundation. And that's really the goal of all our work here. And so even though we are talking a lot about climate change and greenhouse gas emissions, in part because it's the easiest thing to measure, and also it has been identified as the greatest threat of the 21st century, it's not the only thing we're worried about. And very briefly, there are lots of chemicals of concern, over about 100,000 in existence. Unlike pharmaceuticals, there's no requirement to prove safety before introduction to the marketplace. And the burden of proof has been very similar to the tobacco story, where there's all these complex, multifactorial issues going into disease, and then the burden of proof has really been placed on those who've been harmed before anything could be removed from the marketplace. And so there's a movement to flip that approach called the precautionary principle, which, like pharmaceuticals, we should prove safety before introduction to the marketplace. But the cat's out of the bag. These chemicals are ubiquitous across the planet. And health sector is a leading purchaser of chemicals. So whether we're not aware of it or not, and just focus on our practice, taking care of our patients and doing our job and feeling good about it, we are part of the issue here. On the right, you're seeing a famous image from the Environmental Working Group, started the whole body of work and an investigation called body burden. And this initial study was looking at 25 cord blood samples across the United States, just looking for something like 267 chemicals of concern out of those 100,000. And virtually every one of those chemicals was found in every single cord blood sample across the United States. So babies are being born polluted. We're contributing to this, and so we really need to be mindful of the materials that we're consuming, the materials that we're inventing, how we're managing those materials. And so climate change has been called a health emergency. We've already seen 1.2 degrees centigrade average surface temperature warming. That may not seem like a lot, but it's average. There could be 40 degrees different between the poles on any given day. And the Paris Accord asked us to try and limit that increase to 1.5 degrees centigrade. Paris Accord aspires to below 2, but aspires to 1.5. And we're likely to reach that between 2030 and 2052. And so the global mandate is to have emissions by 2030 and get to net zero by 2050. On the left, you're seeing business as usual projections with the uncertainty, current policies and pledges, and then what it's going to take is a lot more action. It's possible within the laws of physics and chemistry. It really is about our decision, political action. So what does climate change have to do with human health, with health care? Since this is a topic the audience is very familiar with, I'm just gonna keep it very brief. Climate change is not itself a direct cause of disease. It exacerbates existing health threats and introduces new challenges. And of course, it disproportionately affects those most vulnerable. So those who are very old and young, those who live in impoverished neighborhoods, which are a lot of the most vulnerable areas. So it does discriminate. And so it affects public health and well-being differently. And so part of addressing climate change and the health impacts and public health impacts means addressing the social determinants of health. And so what about climate impacts and health systems? So altered and increased disease burden, but we also see structural risks. So infrastructure damage, interruption of electrical and water and sewage services, interruption of ability for healthcare workers and support staff to get to where they need to be able to take care of patients, and supply chain interruptions. So there's a lot of similarity to the COVID pandemic in terms of supply chain interruptions, and a lot of the solutions are actually quite similar. So these are annual occurrences across the world, but even across the United States. These are just a couple of famous ones that affected me personally. When I lived in Connecticut, there was Hurricane Sandy. The year prior was Hurricane Irene. My street was actually flooded and had to be evacuated by the National Guard. You're seeing on the left are famous images from Langone Health Center. On the right, of course, the famous campfires and the Adventist hospital that was evacuated, and within hours it caught fire and was eventually razed to the ground. So these are affecting us directly. And then, of course, supply chain disruptions, and very famously with Hurricane Maria, which devastated the island of Puerto Rico, where Baxter had a lot of its manufacturing plants, and some of those supplies, it was a sole source of manufacturing. And so what made national headlines were saline shortages. There were also drug shortages, and the saline shortages, particularly small bags, which may not seem like a big deal, but to be able to infuse drugs safely, we have pumps that are programmed, we have habits, we have protocols in how we do our dilutions. And so having to substitute different size bags presented patient safety concerns, actually led to cancellation of elective surgery, so it affected the bottom line. And we also saw this interesting phenomenon that affected our specialty in anesthesia, and that was a paradoxical increase in drug waste. So on the left, you're seeing a small vial of bupivacaine, which is used for delivering or doing a spinal anesthetic under sterile conditions. Those small vials were had run out. And so instead of a 2 ml vial, we were substituting a 30 ml vial. And your solution is to throw it out, to split it under non-sterile conditions, which is dangerous, or to quickly try and institute protocols to split it under sterile conditions. And these things take time. And so these are just some of the examples of how we are already been impacted by supply chain disruptions. So that was just a tiny bit about how climate change impacts health. And now what does healthcare have to do with climate change? And so, hospitals are a large part of the footprint here, and they run 24/7 high-tech diagnostic and therapeutic equipment. Unlike other industries, the only industry that maybe comes a little close is the food industry, but we have very unique requirements for infection prevention and very unique risks. We have a very complex regulatory system, and we have business models that drive wasteful, unnecessary utilization of resources, and anybody here as a clinician can relate to that. And our culture, we have a culture of excess, where we're not used to running out of things. We're used to having more than we need. And disposability is normalized. We think it's normal to use things once and throw that away. That needs to be disabused. We also have a social mission to our individual patients. I feel really great when I take care of patients. I'm sure all clinicians do. But what about public health? We need to widen our lens of what we think about as a clinician. And so this is our work with the Lancet Countdown on health and climate change. in order to be able to understand how big is the problem. We've done this on the national level and international level, and we found that internationally, healthcare is responsible for 5.2% of total global emissions. Healthcare is 10% of the global economy, so it stands to reason it's a big emitter. In the US, it's 20% of our economy, it's 8.5% of our nation's emissions. And of this global 5.2%, the US, a quarter of that's coming from the US, and we are only 4% of the global population. And healthcare emissions are rising faster than the rest of the economy. So in the US is number one, and not in a good way, the highest per capita greenhouse gas emissions of any nation. Now, if we had the best health outcomes for those emissions, we might be able to justify it until we figure out greener ways of delivering care. But we're not. So if we plot our greenhouse gas emissions per capita for healthcare along some measure of healthcare quality, in this case it's the Institute for Healthcare Metrics Healthcare Access and Quality Index. We've also done it with a number of other healthcare quality indices. And the story is the same. The US is an outlier in terms of emissions and does not have the best healthcare system. And there are a lot that are performing much better and with lower emissions. So the good news is that there is room for improving healthcare access and quality and either maintaining or reducing healthcare emissions. And so we know that 1/3 of healthcare in the US is low value. It's 1/4 globally, meaning ineffective, unwanted, excessive, and so forth. And 11% of the US population lacks access to health insurance, half the world globally. So we have about 4 times the emissions of sort of the break-even point, around 400 kilograms carbon dioxide equivalent. So the good news is that there is opportunity to do better while maintaining or improving health care. So even though we're talking a lot about greenhouse gas emissions, there are other emissions of concern. And when we start throwing these numbers around, I can tell you as a clinician, I don't know what a kilogram of CO2 means. What does that mean in the world? So things I can wrap my head around are things like disease burden. So when we wanted to translate, we try to always translate these numbers into things that people can identify with. And so on the national level, we did that. My research partner, primarily Matt Eckelman, who's an environmental engineer at Northeastern University, that if you look at greenhouse gas and non-greenhouse gas emissions combined, the disease burden is about 388,000 disability-adjusted life years lost annually, especially from particulate matter, which stems from fossil fuel combustion, as do greenhouse gases. And so if you go to the root cause of that, a primary solution here is going to cleaner energy. The other important finding here, or stretch, is that when the 2 Eras Human came out in 1999, 2000, it really sparked the patient safety movement. We thought we were doing a really good job in keeping patients safe until this publication came out and found that deaths due to medical errors, it was one of the leading causes. And so at that time, between 44,000 and 98,000 deaths due to medical errors were identified. The actuaries say it's about 10 years of life lost for each of those deaths. So if you multiply, it's a different metric, but if you multiply by 10, you see we're in the same order of magnitude, and that really matters. This Eras Human report sparked the patient safety movement. Everything we do in healthcare now is through the lens of patient safety. Pollution prevention, healthcare pollution is on the same order of magnitude, and it really should be the new patient safety movement. Everything we do should be through the lens of also protecting public health and preventing pollution. And so just very briefly, a lot of the language of greenhouse gases is through the Greenhouse Gas Protocol. It is the international framework for how we count emissions coming from a thing, an entity, an organization. And why this matters is because we need to count things the same way to make sure we are comparing ourselves to others in the same way. Who's a good performer? Who's a bad performer? How do we have our emissions by 2030 and get to net zero to 2050? We have to count things to get there. So scope 1 emissions, You've heard those are the emissions coming directly from an organization, whether it's through on-site gas boiler or release and inhaled anesthetics off the rooftop. Scope 2 emissions are indirect emissions associated with purchased electricity, steam, heating, and cooling. And Scope 3 is everything else, and most notably the supply chain. So all the things we're buying and throwing away. And multiple studies have found a similar story. 70 to 80% of those emissions are coming from Scope 3 or the supply chain. And why this matters is it tells us where to focus our effort. We've had a lot of great presentations this morning from all the outstanding work in the organization here at USC, particularly on Scope 1 and 2 emissions, and the challenge everybody faces is Scope 3, how to measure it, and therefore what to focus on. So we know that the vast majority of emissions are coming from the supply chain, not just the clinical supply chain, also facility supply chain. And on the clinical side, the outliers are pharmaceuticals and chemicals, medical devices and supplies, and food, things we have a lot of direct control over as clinicians. And also, about 5% of these emissions are coming from anesthetic gases and metered dose inhalers, or the propellant in metered dose inhalers, which is why that is a focus of interest, but the rest is a big challenge for us. And so clinicians, we control consumption of these resources, so do administrators and regulators. So the consumption and waste, meaning inappropriate use of these resources. And the emissions intensity, what's embedded, that really falls more to the designers, manufacturers, regulators, about what goes to marketplace. And so the two different big ways of thinking about how to have an impact is addressing inappropriate consumption and addressing the emissions intensity embedded of the stuff that we use. So I always try and think of how to impact change through those two different ways of thinking. Now, of course, you've heard about, and you'll have a fabulous talk by Dr. Nick Watts about what the National Health Service is doing. So here's an application of the greenhouse gas protocol. But that greenhouse gas protocol helps for external accountability. The other thing is, what do you do with that information, the internal strategic management? And it all starts with benchmarking. And so what you're seeing is their trajectory since they measured, and also when they broke down and understood where all those emissions are coming from, and then used the best ideas about available technologies and interventions, and tried to project how long it would take to implement those changes. That's how they're able to develop their strategic plan to get to net zero. And so just very briefly about my own health system. So I'm in New Haven, Connecticut, 7 hospitals, mostly in Connecticut, but also in Rhode Island and New York. Flagship hospital where I work is really quite large, nearly 1,600 beds. And then across the coastline, you see we have over 200 clinics. And so we are very prone to hurricanes and flooding, and and we've already been affected, as you already heard very briefly. So as has your organization, we did our own baseline accounting, and again, one of the things that everybody struggles with is what to do with Scope 3. We actually developed, a free calculator, healthcare.ghg.org, and that's what we used here to look at our different hospitals and understanding how big they are, right? So it's not just what the emissions are, but how do we normalize those emissions? What's good, what's bad, and then what are the big outliers in terms of what we should focus on? And so when we think about normalizing what's good performance, what's bad performance, it's not enough to know what the absolute emissions are, how big, and so licensed bed or bed day or some metric of clinical utilization is important here, but we also, it's not just what the clinical utilization is, right? So it's also what's best practice. So here you're seeing the 5 main hospitals in our health system, and so the first one is normalized by dollars spent, and it looks like our flagship hospital is doing pretty good, keeping in mind that this one has 3 times the amount of beds as the others. And then if we look at CO2 emissions per bed, it looks like we're doing worse, but we also have the most complex care, highly specialized care. And it looks like this other hospital, Greenwich, is doing nearly as well. This Greenwich hospital is a very small private hospital. It does very little specialized care. So I would say that Greenwich is actually not doing well. But when we think about how to normalize performance, we have to take into consideration type and number of clinical services, comorbidities, payer mix, and the future of healthcare organization accounting really has to incorporate normalization based on clinical outcomes. And so we did this exercise when we did our scope 3 emissions and just ranked them in a similar way based on spend. You know, a lot of this modeling uses top-down economic input output modeling, and so roughly the more you spend, the more the emissions, but it doesn't work perfectly that way. But certainly organizations who are looking at cost containment are also very interested in those areas with high spend, so we rank both of them to try and find out areas that are of common interest to work on. I'm going to shift gears briefly, and because when we talk about why we use so much stuff, a lot of it has to do with our mission, which is to prevent harm, and that includes healthcare-acquired infections, which are the #1 adverse event globally. Over 700,000 annually in the United States, 75,000 premature deaths annually just in the United States. And this data is already quite old, 6 to 7 billion in excess healthcare expenditures. Not only is it our mission to prevent harm, including preventing infections, it also prevents pollution, because if we, you know, I would never say don't use something just to prevent pollution, right? Because if a patient gets infected, then they're going to require more care, right? So it's really about striking that right balance. But unfortunately, this goal toward infection prevention is driving this trend toward excessive consumption of single-use disposables, and also to drug waste. So we have to throw things away that are quite good, even if they are not dirty, because of how we manage things to prevent infection. So just, I know it's hard to read this, but I'll just explain the big things, and that is the red line here is the infection rate over history, and the blue line is survival, and this is about a particular type of intervention, and that is a surgical intervention, for example, amputation of a leg. So it used to be, if you go back historically, you had about a 95% chance of getting a surgical site infection, about a 40% chance of survival, not great odds. And then you see this great big decrement here, this steep slope. And along came Semmelweis and Pasteur and Lister, so germ theory, and then the development of antiseptic and aseptic techniques. So that was the most important thing that happened in the history of medicine to prevent healthcare-acquired infection. And then along time, you see another blip here, and that's the time period between First and Second World War, the introduction of antibiotics. And so that was the second most important thing in the history of medicine for preventing healthcare-acquired infections. And then you see here, we're approaching 0 asymptotically, so you have less than a 5% chance of being infected and greater than a 95% chance of survival. So but if we blow up the bottom of that curve, you see, again, we're asymptotically approaching 0, and we've got this mandate, 0 harm, 0 healthcare-acquired infections, throw anything at it we possibly can, and we're ignoring the rise of the indirect disease burden from all the stuff that we're using. And really, we need to ask the question, is the goal of 0 healthcare-acquired infections realistic? And what are those indirect damages? Where is the right balance? I don't know the answer, but that we need to look at it because we're way out of balance. And in fact, causes of infection are multifactorial. We know the most important thing we need to do is wash our hands. Even in rich nations that have plenty of access to water and have ubiquitous access to waterless soap, we don't wash our hands enough. The other important contributor to infections are patient health status. Are they immunocompromised? Do they have diabetes? Do they have cancer? And other things obviously important are the exposure site, the type and the quantity of the inoculation, whether or not they got appropriate antibiotics, and so on. But most importantly, those first 2 things we know are key. It is hand washing and patient host status. neither of which are going to be solved by throwing more and more disposables at the problem. In fact, you can contaminate a disposable just like you can contaminate a reusable. And so we know we have a plastics problem. By 2050, business as usual, there'll be more plastic in the ocean by volume than fish, and not just at the surface of the ocean. This plastic is also at the depths of the ocean floor. There's no place that it has been found that is plastic free, and it's not just macroplastics, microplastics. I cannot even keep up with the literature. Microplastics found ubiquitous in table salt around the world, in our tap water, found in our stools, found in wild animal stools in remote locations, actually raining down for microplastics, found in our blood, found in placentas, found in breast milk. And it's not just the microplastics, they are laden with chemicals, right? So you may see a phthalate-free label on a lot of our medical products. So phthalates are a class of chemicals added to plastics to impart desirable characteristics, for example, pliability, great characteristic. The chemicals are ionically bound, they leach out very readily. A single exposure to 1 liter of saline fluid, you can measure these byproducts in the urine. And they are endocrine disruptors. And so another problem with our dependence on single-use disposables, as we've seen, as we've experienced, and that is we're vulnerable to supply chain shortages. On the left, these are first world countries. On the left is a hospital in Brooklyn, New York. On the right in London. And we never thought that we in wealthy nations would be forced to ration our supplies, and yet this is part of the outcome of our reliance on single-use disposable goods. We have a global supply chain. Our products are brought together by materials extracted and produced all over the world and assembled in a different location, shipped and stored in a different location. So we have just-in-time delivery. Just-in-time delivery decreases our production and storage costs locally and reduces our local pollution, but it also increases pollution elsewhere. And of course, there are lots of issues with unfair wages elsewhere. So it's a question of, is just-in-time just? And typically we know what's happening with our own supplier. We know nothing about what's happening with their suppliers. And so when we think about trying to mitigate risk of supply chain vulnerability for future pandemics, the same is true for trying to understand and mitigate climate change risks. So this lack of transparency is something that needs to be addressed. And so when we talk about medical devices, we have different classes of medical devices. They have different infection risks, and helping to understand that is also to help understand where to prioritize or how to prioritize addressing the disposability issue. Critical items are those things that contact normally sterile tissues, for example, the intravascular space, and those devices must be sterile. Something that touches mucous membranes, like the mouth is dirty. That equipment does not need to be sterile, but it does need to be high-level disinfected. Or something that doesn't even touch mucous membranes or sterile, something that touches your skin, like a blood pressure cuff or a pulse oximeter probe that goes on your finger. On the right, you're seeing an ultrasound probe being cleaned with a chemical cloth. So it requires low-level disinfection cleaned at the point of use. So part of the trend I'm going to take from my own specialty of single-use disposables is this laryngoscope, the tongue blade and the handle, 2 different components. On the left is a reusable one. On the right is a single-use disposable one that my institution switched to because someone in the Joint Commission said that they had to. I wasn't sure what that meant, and I had to dig in deeper. And what I found was that this handle, which was traditionally considered low risk, just touches your hand, actually touches your gloved hand. Someone said, well, it could touch the tongue blade when you fold it, and this goes in the mouth, and this is intermediate risk, and so therefore this should be considered intermediate risk too. Now that is not evidence-based. It was someone well-intentioned or someone who was taken out to lunch by someone, I don't know, but basically said, well, the handle should be intermediate risk as well. So your choices are, instead of cleaning the handle at point of use, You can create a whole new infrastructure in your facility, send it down to sterilization supply department, have a whole work stream created, and then bring it back to your department, or shift to single-use disposables. And what's easier, just like your coffee to-go cup is easier to just go to disposables, a wave across the United States of going to disposable devices. This is one of thousands of devices, just as an example. And this particular vendor said, go with our product, it's recyclable. Well, anybody who does anything with recycling knows that with this many components and nobody to disassemble them, chances are it is not going to get recycled. But nonetheless, our procurement team didn't know any better. The vendor said this is recyclable, so they're going to go with that. So it highlights this issue of greenwashing, of which there are lots of nuances. This is from Planet Tracker, a nice, really nuanced way of breaking down. So green crowding, when a company hides a statement in a crowd of statements. So now every company, anyone who's working in supply chain knows, pretty much every company has some statement of the sustainability of their product, whether it's true or not, but they're hiding in this crowd. Green lining is drawing attention to a desirable quality and away from or distracting from an undesirable quality. Green shifting is saying, well, if there's a problem with this, it's your fault, so you should recycle it. So that's how Coca-Cola began the whole recycling movement, bottle recycling movement, which has not worked. Green labeling, mislabeling, or misleadingly calling something sustainable. Green rinsing, and that is, if people are familiar with ESG, it doesn't have to just be ESG, but if you create a sustainability goal and then you change the target if you haven't met it. Or green hushing, which is hiding which is an interesting thing. It's hiding or reporting your sustainability efforts because it's frowned upon. That was an interesting thing. But ultimately, it's a practice of making unwarranted or exaggerated claims of sustainability or environmental preference in an attempt to get market share, or not just market share. You can also see with hospitals, we are sustainable. Well, how are you sustainable? We need a standard way of measuring and reporting. And so I've given you some examples of top-down accounting. So the high-level emissions accounting, whether we're talking a national healthcare organization, international, these systems are so large that you have to do, the method is to use an economic input-output modeling, so understanding how things move throughout the economy, and then having average emissions intensity for the stuff. That's how you deal with very large systems. And the great thing is that it's very inclusive of the global economy. Part of the downside is that the results are average. So if you want to do strategic management, you need something more bottom-up or process-based, more detailed level accounting. But it's much more labor-intensive to understand all materials and stuff that goes into a thing or a system. But that is how you can redesign a product or do a local intervention. And that's where the science of or the scientific tool of life cycle assessment comes in, a modeling tool for quantifying total resource and energy inputs into a system over the product's life cycle. Stuff I never thought about in my medical training. I tend to think about stuff when we use it, maybe think about what went into making it, probably not even thinking about all the natural resources that were extracted, and then what happens when we throw it away. And need to consider the entire system to understand where the issues lie and to be able to compare alternatives, not just what we throw away. And importantly, even though we talk a lot about greenhouse gas emissions, it's not the only emissions of concern. We have to be very careful we're not shifting one problem to another problem area. So we use this for design and decision support. So here's an example of an LCA we did on that reusable and disposable laryngoscope. And on the top, you're seeing all the things that we consider for the single-use device, so raw material extraction, all the way to the use in the solid waste management. So for the reusable, it's not just one-to-one, right? We can reuse it. So in fact, this particular device was rated for 4,000 uses. So we had to consider, for one disposable, we considered one raw material extraction, transportation, packaging, then we used it, and then we had to consider all the energy and materials that went into cleaning and repackaging it, and then 1/4,000th of the device thrown away, and then 4,000 packages. So you have to, have to compare like to like. And we also looked at costs, including refurbishment costs, as well as labor and waste disposal fees. And just squinting at this, because there's a lot of information here, we had single-use disposal, plastic and metal alternatives we looked at, comparing to different cleaning protocols that were acceptable, because we also over-clean things unnecessarily, which is another area of opportunity improvement. And if you just squint at this, the gray being the disposable, 7 times more on average than the reusable options. Now people said, and the vendor said, but you can recycle it, it's okay. Well, the red is the waste management phase, and the study, the baseline was you looking at average waste disposal management in the US, so a fraction gets recycled, a fraction gets landfilled, a fraction gets incinerated. What, for the sake of the argument, would it look like if we could 100% recycle all these materials? We know we can't, but for the sake of argument, that's what the bar is showing. And you can see it didn't really put a dent in things. In other words, we cannot recycle our way out of our problem. And importantly, when doing these studies is to understand that they're context specific. So we based our model on average US energy mix, so it's going to look different, slightly different in different regions in the United States. If you did the same study in the US, in Europe, which has far more larger fractions of clean energy, the reusables look several times more favorable than the disposables. If you did the same study in Australia or even China, which is highly dependent on brown coal, and compare that to single-use disposables, actually the single-use disposables look slightly more advantageous in Australia or even China. Does that mean that in those countries they should be using more disposables? No, it means that they need to clean their energy mix. But this is important to show that these studies are context specific, and so when you interpret them, you have to do that with that in mind. So we did also look at costs just to my department. We're not the only department that uses laryngoscopes, but we looked at just my department, my institution, annually. Going to disposables increased costs about $700,000. Our central sterilization supply department did not need to add more staff. We processed about 12,000 instruments a day. This would have added about 167 on average a day. They would not need to add more staff, but even if they did, it would still be cost advantageous to the health system. And this also highlights the importance of being careful to not silo cost assessments. Or when somebody comes to me and says we can't afford it, I want to see how they did their calculations, because if they're just looking at their silo, maybe it does increase cost, but maybe money needs to be shifted from a different department. So we really need to break down silos when we do this work. So another argument I got, well, we lose these things, and therefore we should just go to disposables. Well, we did, as we often do in these analyses, a break-even analysis. How many single-use disposables does it take to reach parity to a number of uses of reusables? And what we found is that if you could get at least 4 to 5 uses out of the handle, 5 to 7 of the blade of the reusable before you lose it, that is the equivalent to about 1 disposable. And then the cleaning time. These take about 2 minutes, adding up all the steps to clean. What was a break even in a cleaning time? And these devices are rated for 4,000 uses, and so if you can't get 8 or 9 uses out of something rated for 4,000 uses before you lose something, the answer isn't going to disposables. It's training your staff better. And so just another example of a common device that people are concerned about now, and that's the pulse oximeter probe, which people are quite familiar with since the pandemic. It used to be that these were all reusable. There's a similar device that people have at home. This probe portion exists in a common disposable form. There's also this idea of reprocessing, which I'll show the slides momentarily. Reprocessing just means cleaning something, but there's a third-party industry that will take single-use disposables, clean them, refurbish them, test them, repackage, and resell them. And so we compared all different options using life cycle assessment, and just staring at the relative numbers here. The disposable had the worst emissions, reprocessed slightly better, Depends, this is not overall across your processing industry, it's per device. And then the reusables had the most favorable outcome. And when we did the cost analytics, including cleaning, materials, and labor across our health system, we found $4.4 million. So we are now in the process of shifting back. There's a lot of challenges to that. If people have questions, happy to discuss. And just another hot area that people are working on, and that's surgical instrument trays. Just one example from our pediatric section at my health institution. Just one division, it's actually a very small division, we only do about 6,000 pediatric procedures a year. And just in device cost avoidance, depending on the division, up to $500,000 found, and then 35,000 in labor. And that's just one small division. This is a big area of interest, millions of dollars in unnecessary cleaning of these kits, which are larger than we need. And so there are different ways to try and pare them down, and it must be pulling out things that are rarely or never used, but it has to be balanced with the risk of not having something there. It's a life or death if you don't have something there, even if you rarely use it. And so what does disposable mean? You've heard a bit about medical device reprocessing. What is a disposable medical device? It's actually an industry label. It's not a regulatory label, it's an industry label, SUD. Does not mean that you can't reuse it. What it does mean is that whoever cleans the device assumes risk and responsibility that it functions as intended. Hospitals didn't want this risk. This was part of the whole story of manufactured obsolescence in the medical device industry. And so they just started throwing the stuff out. And it turns out that then a new industry sprung up of third-party reprocessors. Well, they took these devices. There's a strict regulatory process through the FDA that they have to go through to be able to ensure that it's done safely. Industry tried to push back and said it wasn't safe, and in 2008, the Government Accountability Office, under congressional mandate, did an investigation and found that third-party reprocessed instruments pose no increased risk compared to reusable devices. Unfortunately, only 2 to 3% of our medical devices are presently reprocessable, and far few of them are actually collected. But we've learned through the pandemic, under emergency conditions, we've had to clean things that were not intended to be clean, were not durable. We had to figure out how to do things safely, whether it's a respirator mask or gowns. But it turns out, or in this case, I'm showing an example of a video laryngoscope cover. We've had to, under duress, figure out how to clean these disposable items. But if we can safely clean disposable items, and we can safely clean reusable items, it begs the question, what's the difference? Why do we have so many disposables? So there's this concept of the linear versus the circular economy. Linear, or take, make, waste, where we do material extraction, we make something, we use it, and then we throw it away. The circular economy is designed like nature. There's no such thing as waste in nature. The waste of one system is the feedstock for another. And so that's really how we have to design every single material that we use. And so we want to retain and reuse things as long as possible, refurbish them, repair them. When we can't use them anymore for their intended purpose, then we repurpose them for another purpose. And the last thing you want to do is recycle. It's really a low-level solution, but perhaps better than nothing. But of course, redesigning things to begin with is really important. So I'm going to switch gears and talk to another area. I told you inhaled anesthetics and metered dose inhalers are hotspots. Metered dose inhalers, the propellant used to be CFC or Freon that was phased out in the Montreal Protocol, trying to address the hole in the ozone layer. It's great, we've practically healed the ozone layer, but it was replaced with a potent greenhouse gas. So a single albuterol inhaler is like the propellant is the equivalent of about driving 200 miles. More than 55 million prescribed annually in the United States, the equivalent of about over 500,000 cars on the road. So the NHS found about 3% of their emissions come just from these inhalers. There are alternatives. There are dry powder inhalers, softness inhalers, nebulizers that have about 1/10 to 1/20 of the emissions. And Sweden is now down to about 88% of the dry powdered inhalers. You can't get to zero, but they've really set the bar of what fraction we should aim to in terms of how much we should use these. So that's really become the gold standard in the US, or about 75% on the pressure meter dose inhalers. So we did an assessment at our own institution, across each hospital. What was our footprint just coming from metered dose inhalers? This is just our hospital. There's also outpatient prescribing. But one of the things we noticed was that one of our hospitals, even though it's about a third the size of our flagship hospital and has, more like an eighth of the emissions, and we found that back in 2011, they had shifted away from those metered dose inhalers for a cost reason to more nebulizers in hospitals. It's very complex to do the change management. Happy to have that conversation, but this is a really hot topic right now. And at least in our own institution, we're able to say one part of our system made this change. We can do it, and so that's really helped grease the way. So you have to find the wins and find the ways to make the change. Shifting gears very briefly, inhaled anesthetic pollution. We breathe these gases in to go to sleep. We breathe them out. They're essentially just blown off the rooftops. They're very potent greenhouse gases. Some of them are destructive to the ozone layer. We need greenhouse gases to support life on Earth, but we have more solar radiation coming in that's going out. So that infrared radiation is what's being trapped and warming. The outer layer, that's where the ozone layer is, and that's where particularly nitrous oxide is having detrimental effects. So one of our life cycle assessments was comparing different inhaled anesthetics. You've heard conversations about death strain. It has about 20 times the emissions at assuming higher fresh gas flows of sevoflurane for the anesthesiologists in the audience. So sevoflurane at 2 liters, death strain ISO at 1 liter per minute. At the same fresh gas flows, about 40 to 50 times. And nitrous oxide, you can add a proportional amount of nitrous oxide, makes everything worse. So the takeaways here, death strain, nitrous oxide, from a life cycle perspective, the outliers and opportunities to address. And then propofol, you can't even see here, and that's because the emissions are several orders of magnitude lower. And so if you can substitute propofol, here's an opportunity to reduce emissions. We also did life cycle assessments of the 20 most common intravenous drugs we use in the operating room. These are also, many of them are used throughout other aspects of the hospital, just that's my perspective, where I'm coming from. We also looked at waste. We know that we waste a lot of intravenous medication, and particularly at the point of use, because we prepare them, or so the clinicians get the vials of drugs, or the nurses on the wards. We reconstitute powders, we dilute them, we draw them up, we administer them. There's a lot of drug waste happening. And so anywhere from 30 to 80% on average, depending on the drugs, just being thrown away. We could build hospitals for all the drugs that we're throwing away. Look just in our flagship hospital, there's the 20 most common drugs, one hospital. If we were to split the vials that we buy under sterile conditions, we found an opportunity of $1.2 million. What we were throwing away was around 22,500 kilograms of CO2. That's the equivalent of driving around the planet twice. So here's another area of interest. So one opportunity here is to reduce waste through what's called pre-filled syringes. On the left, you're seeing manufacturer syringes. They have a lot of packaging. They're for emergency uses only, not for routine use. There are third-party vendors where a hospital buys a drug and goes to the third party where they split them under sterile conditions. It's a little bit cheaper, a lot less packaging waste. Or you can do it in-house using your own pharmacy department. It's the cheapest, but they also have the shortest shelf life unless you're sending out for independent laboratory testing. So these are also areas for cost saving and improvement. And also optimizing drug packaging size. So common example is insulin, where patients are rationing across the United States, and there are deaths from rationing insulin. In the operating room, when I first started, the vial we got was typically 10,000 units. I would typically use, we've studied it, between 5 and 10 units per a patient. The rest of it has to be thrown away. At least first we shifted to a 3,000 unit size, then we started having our pharmacy manufacture 100 unit bags, which also helped reduce medication errors because it's 1-to-1 versus this requiring double dilution. Now you can get a pre-filled syringe of about 5 units. So This is a strategy to improve patient safety as well as reduce cost and pollution. So I gave you some examples of health systems, devices, drugs, clinical care pathways is next. So there are alternatives to inhaled anesthetics, and if a patient doesn't always have to go to sleep, sometimes they can get just, for example, their arm numbed up, or a spinal anesthetic, or this is intravenous. And if you just squint at this, you'll see we hypothesized if you did an anesthetic that had inhaled anesthetics, the emissions would be a lot greater. That's what we found. So sometimes you need inhaled anesthetics, but the point here is that if you have choices, an environmentally preferable choice would be to avoid that. Same thing can be found with surgery. This is the work of Dr. Cassandra Thiel, who did her PhD thesis looking at emissions related to hysterectomy. So you can see an open abdominal or vaginal assisted approach versus a minimally invasive laparoscopic or robotic. The big error bars is because some of these use propofol anesthetics, some use inhaled anesthetics. And some of the big takeaways include inhaled anesthetics, that's the purple, that's a big fraction, 2/3 to 1/3 depending on the approach, but the rest is all the single-use consumables. And a big opportunity for inquiry is looking at robotic surgery, because from a clinical outcomes perspective, robotic surgery has not been shown to be advantageous from laparoscopic surgery. The emissions are a lot greater. And then what about looking at examples from other places in the world? Also the work of Dr. Cassandra Thiel. If you did common eye surgery, cataract surgery in the UK, if you did the same study, the same procedure at the Arabian Eye Clinic, you can see a few kilograms of carbon dioxide versus nearly 130. And this is just looking at the solid waste of one cataract surgery from the US at the top and from 90 at the bottom in the UK. So there are lessons from us to learn from low-income nations, but importantly is also the clinical outcomes, right? Because if the clinical outcomes are worse, then that's not the model that we want. This is a low-risk procedure with equivalent clinical outcomes. And then finally, I didn't really get a chance to get into this as an intensive specialist. I think less about these things, but from a systems thinker, we obviously need to move upstream to disease prevention and better chronic disease management, developing more green spaces, active transportation, physical activity, whole foods, plant-based diets, addressing social determinants of health, and obviously we need accessible primary care. And these are all areas of important inquiry. And so finally, thinking about this net zero healthcare, it's a common term that we use now, but really it's a planetary healthcare framework that we need. So the three strands of thinking: reducing emissions embodied in the services that we provide, mention electrification, clean energy. If we electrify without clean energy, there's no benefit, but we need to clean up our electricity sources. We need to shift to the circular economy and have better resource stewardship. Then there's this idea of managing supply and demand, which is a whole other talk, and that is avoiding inappropriate care. We provide so much care that is ineffective, not needed, not wanted, that is a whole area that we need to really address. But this idea of moving upstream and removing demand for health care to begin with, through health promotion, disease prevention, addressing the social determinants of health, we have to do these things together, because if we don't change the way that we deliver care, we cannot transform our system. Then ultimately what we think about when we think about high value care, getting back to the triple bottom line, the best care for the most patients at the least cost, but the least costs are not just financial, they are also environmental and social harms. And with that, thank you for your attention.
So if the panelists and Dr. Sherman could take a seat here at the front of the room. So we're going to start with the panelists, and each panelist can make a comment and ask a question for discussion, and then we'll be sure and leave a little time for questions from the audience, both in person and online. So we'll start with Bhavna at the far end.
Thank you, Dr. Sherman, for that wonderful talk. My question to you is posed as a sort of introduction. So education in sustainability is central to our assignment Earth goals here at USC. What are key concepts that you would recommend pre-med and medical students to prepare for the changing field of healthcare?
I think that part of it is to really understand that there are going to be health impacts that we're all going to see from pollution and climate change, and to begin to understand or try and inquire what those are going to be. There is global effort and movement to infuse education on the health impacts of climate change into professional education. It's not yet required in the US, although there is effort to get the AAMC to require that, and also it needs to come from graduate medical education as well. So I would say that if they don't have those opportunities anywhere, then they need to advocate for them.
Thank you, Dr. Sherman. It was enlightening talk. Thank you. I'm very interested, as I may have mentioned to you, about the interaction between decarbonization and patient safety. You had a very interesting line that I wrote it down. Pollution prevention is the new patient safety movement. In fact, that's very interesting because I'm on the governance board of Patient Safety Movement Foundation. And that, I'm going to bring that to the attention of my colleagues. I want to know that, for example, when it comes to, you mentioned about hospital-acquired infection. And what about other type of a patient safety, things like wrong site surgery and others? How do you relate those to decarbonization? Thank you.
Thanks for that great question. I would say that just like we put in a lens for patient safety, that lens needs to be adjusted to look at all those times that we're unnecessarily consuming resource and look for opportunities to pull that back. So this idea of zero surgical site and zero infection, it's not achievable. We need to minimize those. But the problem is that if we don't have a goal that is achievable, we're just going to continue to overshoot. And so when I think about a wrong site surgery, anytime an institution has a critical event, they need to do a corrective action. And I don't know about your experience, my experience are corrective actions. Usually it's to check a box to say that we did something, and it contributes to a lot more resource consumption. And so we need to be careful that we're not just checking a box with a corrective action, and that whatever corrective action that we take is not unnecessarily leading to overconsumption of resource.
Thank you.
Thank you.
Thank you, Dr. Sherman, for that great talk. Personally, for me, whenever I look at these life cycle analysis, I get terrified because they can be so complex with everything that goes into it. And there's a lot of talks, clinically about disposable and reusable, and while understanding we don't have an LCA in every single thing, is your, based on your expertise and knowledge, is it safe to assume that in most of these circumstances, reusable will end up having a much lower carbon footprint than the disposables?
Well, listen, things that are cheap and simple and hard to clean, IV tubing, needles, IV catheters, obviously we're not going to collect and clean and reuse those. That said, electrophysiology catheters are primo material for the reprocessing industry. Those catheters are actually intravascular, are reused. They have precious metals in them, so they're very desirable by third-party remanufacturers. I will say that every study I've done or looked at has found reusables to have a lower footprint, but again, it's context, right? Context sensitive. If you did the same study in Australia, they found a slightly different study, slightly different results. So, but by and large, I am convinced that, and again, it's not just greenhouse gas emissions, it's this concept of moving to the circular economy. We've got limited resource. We need to figure out ways of reclaiming, repurposing, reusing. And so I would not advocate for reusing IV tubing, needles, catheters, and so forth, outside of the precious metal EP catheters. But in general, I do believe that we need to be going back to reusables. And again, it's not just, I showed you the greenhouse gas emissions. We can't measure, you know a way, but can't measure the impact of macroplastics on oceanic life and gut health. So, but there's sort of this biological plausibility and common sense that if we can keep materials in reuse, that's going to be a better way. I don't know, do you care to add to that?
Can you speak a little closer to the mic?
So I think that we're growing our knowledge, looking at sustainability from a systems perspective, so thinking about multiple impacts beyond sort of the individual systems that we're exploring. So looking at macroplastics, I think of sort of the impacts on wildlife are starting to be documented more and more. And so when we start to think about where those plastics are originating, we're starting to connect the dots in terms of how one particular area of our society actually has a really broad impact that we would never sort of associate. So that would drive the idea of reducing impacts in particular areas such as single-use plastics. But it's a systems perspective, so being able to look at water, so being here in California, thinking about drought, which we're sort of moving away from right now, but in the future we'll still be under those conditions. Weighing all of those different variables within a single process is an important aspect to understand as well. So it comes back to your talk where you talked about thinking about things in terms of the region as context and making sure that we incorporate that in any type of analysis and decision making that we do.
Thanks, right. So then one of the examples that we'd also talked about is the Middle East, where, it's, when you're in the desert, obviously there's a water scarcity. And there may also be solutions for collecting gray water, being better stewards of our water as a resource, which means the northeastern part of the United States is not something I naturally have to worry about. But the other question that I think was embedded in the question we had is, we don't have this information. It's safe to assume reusables, better than disposables, context specific. In general, from a greenhouse gas perspective, probably true. But it really sort of begs the question is, why don't we have this information? And I firmly believe that the FDA should mandate that any drug or device that is being applied for approval must present this information in a standardized, reproducible way. What does that do with all the stuff that we have? We need to think about how to address that. There are environmental product declarations, so there are models from other industries about how this information can be standardized and made transparent to help better inform decision making.
Dr. Sherman, I'm coming to this business from the safety culture and high reliability organization background for other safety critical industries, primarily nuclear power, aviation, deep water drilling, and others. We have tried to understand the importance of safety culture, which overrides other safety practices. It's a foundation for everything. How can we compare safety culture with sustainability culture? If you want to define a new phenomenon called sustainability culture, because safety culture, the definition is very simple. Safety considerations should have overriding priorities over other considerations. That's the definition by International Atomic Energy Agency, Nuclear Regulatory Commission, Institute of Nuclear Power Operation. Safety has overriding priority. How can we define sustainability culture? Because that, to me, if we look at that movement, that will be the main driving force. One other line that I learned in my lifetime, I read it once in a report that culture eats the strategy for breakfast. And I think if we look at that sustainability, we may have all sorts of strategies and practices, but if we don't have that sustainability culture, then it will be eaten by breakfast. Thank you.
Thank you for that. I think the way that you defined what the mission is, say it again in terms of safety.
The safety culture definition?
Yes.
Yeah, the safety culture definition, the key word over there that everybody has agreed on is safety consideration should have, quote, overriding priorities, unquote, on other considerations.
Right, so I don't think you need to change that. I think what needs to be changed is what we mean by safety. So it's not safety just for the patient in front of you. It's safety for the community, for public health at the same time. The question is, how do you, I don't have an answer, it was more of a proposition, how do you balance that? Because I can tell you as a critical care physician, type of physician, if my patient in front of me is dying, I'm gonna do everything to try and keep them alive in that moment. But there is a point where you have to draw a line. And where is that line? That becomes a political, cultural values question. But there is a line. It's not either or. It's not, we're gonna, I'm not gonna save my patient because some polar bear is gonna die. I mean, that's a ridiculous extreme. But it's also a ridiculous extreme that I'm gonna do everything to prevent this patient. At some point, maybe I can't save this patient, or maybe the patient doesn't want to be saved. So wouldn't want to be saved. So there's some grayness in the middle there. It's about finding the balance. But overall, it is about changing the definition of what safety means. It's not just my patient. It's my patient and population health.
Thank you.
Thank you. It's an interesting discussion. I'd like to open up the floor to people in the audience. If you have questions for either Dr. Sherman or the panel.
Hi there, Dr. Sherman. Thank you so much for the talk today. So I'm a medical student, and it's very interesting to see this kind of thing because I feel like even in my generation, there's a lot of apathy around sustainability if you're in the healthcare field. Like, outside of the small group of people who are very passionate about it, I was wondering if there are any strategies that you or anyone on the panel has used to kind of take this out of the silo of like this grand rounds talk into more consideration in the broader healthcare field. Thank you.
Yeah, thanks for your question. I think that part of it is, as I sort of said at the beginning, is the culture of excess and where disposability is normalized. So I think that we have to address it in all ways, including student interest groups, but including example setting by your teachers. If your teachers don't see a problem, don't make it a problem, think it's normal, or model behavior where it's normal to use excess things and do excess things. And that makes it very challenging. But I think, when I first, this is a simple example, when I first got to Yale University, there are all these food carts where people go outside for their lunch. It's really a wonderful thing, and they have all this disposable styrofoam. And when I first started, there was a student interest group who wanted there to be reusable containers, that there are systems, reusable container systems. And the sustainability community at the time shot the idea down because they said they were getting feedback that it wasn't cool to carry your own container. I'm like, then make it cool. So probably the hardest thing is culture eating strategy for lunch. The hardest thing here is culture change. We have to call out what's not all right and model what is okay and ought to be. And somebody needs to stand up.
Other questions from the audience?
Hi, Dr. Sherman, it's Dr. Muir again, this time it's getting close. My question is, how do we fight industry? Because, you know, over my 40 years in this discipline, you know, a lot of what happens to us is driven by industry rather than fact.
Yeah, that's a tough one. So I think part of it is calling out misinformation or lack of information. If something doesn't make sense to you or to me, I think I'm probably not the only one. So I dig deeper. You say this is recyclable, what does that mean? Show me the data, how this is not just your data, show me what data there is. And so part of it is calling out for information and calling out things that don't make sense. The other angle, I think importantly, is through our value analysis teams and our procurement teams, and having something that's really important is being led by the National Health Service in England, are having policies in place where any vendor that wants to do business with the National Health Service has to do standardized, transparent reporting through an external body called the Carbon Disclosure Project, and has to have transparent progress report and timeline and goals, and called it science-based targets. And in order to do business with the NHS, they have to be doing that. And so demanding that of companies that we do business of is another lever that we have. An additional lever is also addressing from a regulatory perspective. When applying for new approvals, whether it's for drugs or devices, the emissions need to be reported in a standardized, transparent way. And I think for devices, they need to be manufactured in a way that is modular, that can be disassembled, cleaned, and reassembled. If something needs to be disposable, it should be demonstrated that there isn't a reusable solution, or, you know. So putting these policy goals in place, I think, is a way to shift the industry. But you know, it's not going to happen. It's not going to come from industry.
Thank you.
Any other questions from here in the room?
Use this. How?
What seems very clear is that when the clinicians often think that they drive policies in hospitals and have preferences that often take precedence, and patient safety remains, of course, the thing. I wonder, among all the clinicians who are involved in procedure-intensive things, which tend to be the most carbon-producing, what sort of uptake have you seen among the different specialties, whether it's, you know, interventional cardiology, radiology, anesthesia, of course, is deep into this, all the surgical subspecialties, just understanding how each might have approached these or even thought of it is kind of an insight into how we might deal with the mentality of creating a culture among clinicians.
Yeah, I mean, I see that more as a comment than a question, because I don't think that, I think it's institution specific, I think it's specialty specific. So those specialties that happen to have a body of research tend to have more culture and professional society guidance. So a lot obviously is coming from the field of anesthesiology. Within surgery, ophthalmology is another big leader. Radiology is starting to develop a lot of this work. So it's catching on but it really is unique to each specialty. But in terms of who decides what devices, you know, obviously a clinician, you know, an interventional type specialty clinician comes in and says, I need this one device to do what I do. And part of that is, part of the challenge is that the technology is rapidly evolving. So can we say for sure that, you don't need that, or something else is just as good? So how to find the right balance of allowing for new innovation is a tough challenge, but I think requiring questions to be addressed around sustainability, when someone puts in a request, I want this thing, then they should have to fill out a survey that addresses sustainability concerns. But I will say that part of the challenge is having too many different things, right? So a lot of effort is being put into trying to pare down the number of selections that we have for various devices, and that's also strategy in the NHS, a lot of strategy, because it increases complexity of management, expiration, and waste of devices. So trying to simplify things overall is a strategy, but I think having some sort of checklist or requirements to think about what are the things that will contribute to a sustainability mindset will address that, but also allow the room to invite innovation.
I'll add to that for our field. A lot of it is also her having someone who's done so much work in so many publications. It just makes it so much easier for me and my colleagues to say, okay, this is what we need to do. So thank you for everything you've done. I'll add to your last comment, part of the challenge that we've had since the pandemic with supply chain has created an extra layer of complexity. I'll use something as simple as IV tubing. So we had one system that we used to have before. Now we're on 3, considering a 4th, because they keep going on back orders and you can't not do surgeries and procedures. So then you bring a second one, and then now you have 2, and then that one goes back order, you go to the 3rd one, and now we're on the 4th. And that seems to happen with a lot of different things that we use. So that's, in the last few years, that's been a major problem for us.
So just carrying that a step further, what you're talking about is supply chain resilience. And so part of supply chain resilience is not having one supplier. But I will say that part of this manufactured obsolescence that we're seeing is, instead of having supply chain interruptions and inability to fulfill disposable devices, seeing that with reusable. We're using disposable things because we can't replace the reusables. And I think that is manufactured obsolescence. Not all of it, but a lot of it is manufactured obsolescence. And I think that needs to be addressed on the regulatory level.
So we're at 1:15, but we'll give Dr. Mishkati and Dr.
This is a quick question. Many safety improvement in the United States, at least in some industries, they have happened because they were regulatory enforced in aviation, petrochemical, refining. Would you think that either CMS or accrediting organizations would make this enforceable? Can they enact that as part of the regulation for the sustainability issues? Because if there is no regulation, then, quote, there will not be a compliance. Then we are reverting to voluntary prevention. But of course, in California, we have a very successful program, I have to say that, called Voluntary Prevention Program by Cal-OSHA, that has been very, very successful. But again, that's involuntary. It's not regulatory. It's done by consultation group of Cal-OSHA, not by enforcement group. But basically, my question is on the CMS role, and if they can enforce it. Thank you.
Thanks for that very complicated question requiring a brief answer. And it really gets down to the question our medical student was asking, and it really boils down to culture. I mean, nobody wants to be regulated. We want to get there in our own way, in our own time. That's great, except we don't have enough time. And so I think voluntary measures risk us not getting far enough, fast enough. And so I firmly believe that emissions reduction must be mandated. And I think it must be tied to CMS pay for performance. If you don't want to comply, that's fine, then you get no money from the government, that's your choice.
So, thank you very much, Dr. Sherman and our panelists. This is, I think we could go on for another hour. This has really been an interesting discussion. Thank you for coming, and thank all of you in the audience for coming as well.